So I want to thank all of you for coming out tonight. Appreciate your time. This is the second of two meetings that we've had to talk about the parent organization. Some of you were here a little over a year ago, right after we had signed the letter of intent with the other three hospitals, and we were here in this room talking about our plans. Since that time, we've been able to refine our plans, complete, if you will, the affiliation agreement, the management services agreement, and the bylaws that are all sort of part of the dialogue and the documentation that we have associated with the project. Tonight we're going to spend some time about, again, why we think this is important to Littleton Regional Healthcare and the North Country, what we are going to be doing in the region, hopefully, if we get approved, and the timelines associated with that. Throughout my presentation, I feel comfortable, if you do, to ask questions as you like. But if not, there'll be plenty of time at the end of the presentation for questions and answers, whatever works best for you. Before we get started, though, I'd like to introduce a couple folks. Terry Knowles here from Charitable Trust. This is a requirement of the process, so she is here to observe our meeting tonight. And we have three board members here tonight representing Littleton Regional Healthcare. John Starr, Jen Hamlin, and Jay Knoll. Thank you. Oh, and now, and Lori Morgan, my favorite. Four board members. How did I forget her? Let me think the ways. It's going to be painful. That was a painful mistake. So I'm going to go through a series of slides to help me talk through the process and where we've been and why. You can see on this first slide that really it is four hospitals. Androscoggin Valley up in Berlin, Littleton Regional Healthcare, Weeks Medical Center, and Upper Connecticut. For those of you who have bothered to listen to anything I've talked about in the last couple of years, you know I have talked a lot about how critical access hospitals who remain small and independent, in my opinion, are like dinosaurs, and someday they could be extinct if they don't accept some kind of change because the environment is changing on us. These are our plans for Littleton in the North Country to hopefully save us from that, and this is really all about our approach and our friends' approach in the North Country on how we can develop a financially stable healthcare system in the North Country in the future based on all the changes that are coming. The first change that I want to talk about and why small hospitals are challenged is really the Accountable Care Act, also known as Obamacare. And that has certainly changed the entire landscape, if you will, for healthcare, and put a whole lot more new regulations in place, put a whole lot of changes in payments, which I'm going to talk about, and has really made providing healthcare in a rural environment extremely tougher than it had been in the past, and it already has been tough. And as you can see, or will hear, it's very important as we think about the Affordable Care Act that size does matter, and size and scale will help us as we go forward, and that's why we think this parent organization is really important. We are clearly getting pressured by Medicaid and Medicare on a daily basis about reducing charges. The director of CMS has basically said, and CMS is the Center for Medicaid and Medicare Services, has basically said to all the hospitals in the country, by 2018, we want to transfer 50% of your payments to an alternative method, non-fee-for-service, which is what we live on today. And if you think about why the Accountable Care Act was put in place, it was really put in place to save the federal government money. So we know what we get paid today is going to be less for the same work we do tomorrow. So we've got to prepare for that. On the state side, we are also getting challenged. The state has a very unique formula where we pay a MET tax, a Medicaid enhancement tax. They submit it to the feds match it, and then we used to get 100% of our tax back. Well, this year, we paid $5 million in tax, which is a lot of money in anybody's book, and we only got $3 million back. So it's another real challenge financially for small hospitals. And then, as I mentioned earlier, the shift in payment methodology. So as you may know today, we bill for every little service we provide to you. But they want to get us all on some alternate payment mechanisms which may be a capitated system with maybe bundled payments. But all of those different payment mechanisms require small hospitals like us to take on risk that we are not ready to take on, nor do we have a population base that would allow us to take on risk. Hence why I think size does matter. What's unique in North Country? You guys, we all live here. We know the uniqueness of where we live, the beauty, right? But there's also challenges. In the region, and when we think about the North Country, we think about the notches and up. So Northern Grafton County and Coos County. So in this area, we have the most economically challenged citizens in the state, based on county rankings. We have the sickest population in the state. Our population isn't growing, it's very stagnant. You can look at census data on that. And it is increasingly aging and Medicaid eligible. Why is that important, Medicaid eligible? Two reasons. One good and one not so good. One reason is the least of the state at this point in time has expanded Medicaid, so those are patients now that have insurance. Why is it not really good? Because on average, we probably get paid less than 50 cents on the dollar of cost for those patients. On the dollar of cost, not charges, cost. So that is not sustainable either. But it's better than getting zero, which is what we had been getting. But that population is growing, so it puts more of a financial strain on small institutions such as ours. And also in the North Country, you can see we've lost a lot of the large industries. These industries provided a lot of private insurance, and that's declining. And a lot of private insurance companies and companies, such as Littleton's, have switched to a high deductible plan. A lot of folks, when they sign up for high deductible plans, either through Obamacare or with their employer, don't understand the deductibles and the co-pays, and sometimes those are out of reach for people, even though they signed up for those plans. So it is just another point of challenge. So what's going on in the country? In the country overall, and what are small hospitals doing? First bullet's alarming, but that is true. I would tell you there's not a week that goes by now that I don't get some kind of email from one of the industry email systems that I get that doesn't talk about another hospital closing in the country. Not a week goes by. These closures primarily are in rural areas. Some of them are urban areas, but they're closing because they don't have the financial means to support the infrastructure required to run a hospital. This is clearly something we're trying to prevent in the work we want to do. What are other people doing? Well, our friends over in North Conway merged with Maine Health out of Portland. So they looked east to their solution. And they looked to a tertiary care facility out of Portland, a large system. Our friends south of here, New London, Cheshire Medical Center, Alice Peck Day, have all signed affiliation agreements with Dartmouth. Again, small hospitals joining forces with the large hospitals to hopefully make sure they can exist in their communities into the future based on financial challenges. What are we doing? Well, we looked at all sorts of options. We looked at the Dartmouth option. We looked at the model that North Conway's doing with Maine Health. We looked at the Granite 5 that are down in the lower New Hampshire, lower southern New Hampshire. And we studied all those options, and we didn't think it was the right solution for the North Country. So what we think is the right solution for the North Country is 4 critical access hospitals combining forces, gaining scale, gaining mass, gaining size, with a parent organization over these 4 hospitals and an affiliation so we can sort of orchestrate the new design of healthcare in the North Country in a different way than we do today, because today we compete. Tomorrow we need to collaborate. Each hospital will maintain its own critical access hospital status. What does that mean? It means 3 things. They will maintain their own boards. They will maintain their own medical staffs. Therefore, they'll be able to maintain their own critical access status and continue to get the higher reimbursement for that. Each hospital will remain in their communities and provide core services in their home communities. What are core services? At a bare minimum, core services are the emergency room, diagnostics that go with the emergency room, and robust primary care in each of the communities. Now that's an extreme. We hope we can do better than that, but that's what we're guaranteeing each of the communities in the future. And when you think about what the other side might be and a facility not there, we think this is how we can work up from there. But this is where we think the core services have to remain. Why do we think we do this? Well, we all share the same mission and values. We all have a nonprofit status. We all serve citizens in the North Country, and we all believe the North Country is a unique place where we can work together and come up with our own solutions. We're going to all maintain our own identities within the larger healthcare system, and we know, based on studies and based on what we've seen going across the country, that together we can be stronger. Benefits of an affiliation. As I talked earlier, maintains local hospitals and core services in their communities. We can take advantages of economies of scale, whether it's group purchasing, shared insurance products, shared malpractice products, you name it. The more mass you have, the better pricing you can get, and that's really the crux of why we want to come together. We believe we can take advantage of technology at each of the hospitals in a different way than we do today. We believe that the synergies between our systems can actually improve the care that we have in the communities. We're no longer competing, we're collaborating, we're sharing medical records. If patients go from one facility to another, we can do a better job than we have today because we'll be one system. And again, we want to sustain local access. Local access is important, high quality care for the people in their communities and in the region. So the North Country solution is the creation of 4 hospitals in a hospital family. Right? We believe, from what we read and see in the country, no other place in the country is where 4 critical access hospitals are coming together. The normal model is critical access hospitals joining a larger tertiary care facility and giving their hospitals away. We believe this solution is better than that for us in the North Country. So it is an affiliation and not an acquisition. Each hospital will maintain its own identity. Each hospital will exchange some autonomy at the board levels to be able to jointly develop this highly coordinated healthcare system in the region. The new structure, it's a non-profit parent organization, not-for-profit parent organization over the 4 hospitals. Again, with some ceded powers to help to deliver and develop this North Country regional healthcare system. So management. Everything below the line is pretty much in existence, right? We have 4 hospital boards, we have hospital leadership, and we all deliver quality medical service to our community. Everything above the line, we have a new board, which we'll talk about shortly, made up of representation from all of the hospitals. We have some new system leadership, and those items that are listed there are the things we're going to focus on, functions, they're not people. This parent organization is going to be very lean, but those are functions that we want to focus on as we work with the boards at the hospitals. So where are we to date with this redesign? Obviously, we have to only do so much work at this point in time until the Charitable Trust and Attorney General allows us to move forward. But what we have done so far is we have the affiliation agreement process. We've identified the board members who will be on this new board. We've identified the system parent executives, all, again, contingent upon getting approval. We will need to identify the hospital administrators for each 4 hospitals. And some of the next steps, right? We've got to finalize board selection and terms, which we're getting very close on. This entire process is subject to approval. A lot of this stuff that we're talking about with regard to the new personnel and the boards need to be ratified from the new board once they're able to do their job. And a lot of things are required to be approved by the hospital board because this is a consensus building parent organization. Our board members are representative from each of the hospitals and each of the communities. This is a list of our board members to date, and you can see who they are and where they're from. I will note that there are 3 physicians on this board, Dr. Duffy, Dr. McDowell, and Dr. Nielsen. and we think that's a good way to represent our medical staff at this level. But those are our board members on the parent board. Governance. So we talked about the parent board. The parent board reflects the need for all communities to be represented, and they are. All hospitals have representation on the parent boards. The representation is developed based on the size of the hospitals. And we wanted to make sure the parent board has the expertise and commitment to create this high-quality North Country healthcare system. The whole theory behind this plan is consensus decision-making from the parent board with the hospital boards, the parent executive officers with the hospital administrators, so we can all work together on plans and develop consensus as we move forward. In all decisions, major decisions, are required input from the local board, local hospitals. What will not change? And I think this is really important to point out. The charitable mission of each hospital will not change. The operations of each hospital and its communities. Each hospital will maintain its employees and its management team. The hospital assets will stay at the hospital level. There'll be no resources and no revenue really up at the parent board. That will all stay at the hospital level. Each hospital continues to have its own physical, financial, and charitable assets. Very important. The assets stay local. Sorry about that. Over time, what do we think the benefits for you, the citizens of the North Country? Keeping emergency services available region-wide. We think it's really important that 4 hospitals maintain financial viability in the North Country. Better coordinated care in the region. We don't have that today. We have 4 independent hospitals. Enhancement of the North Country's ability to recruit docs and specialists. Again, size matters. People will be excited about the fact that we have a 4-hospital system, and they'll be much more apt to come here and practice. We are all the largest employers in each of their communities. We want to maintain that, because jobs are important in the North Country, as we all know. System purchasing savings can control costs at a local level. Again, we have to get our cost structure down, because I said earlier that revenues are going to be less than what we get today for the work we do, and we've got to figure out how to survive on less revenue. The only way we can do that is to get our cost structure down. And we think we can advance healthcare and keep it closer to home. We know a lot of our citizens in the North Country drive right by us to get services south of here. But if we have a system of 4 hospitals, if we have coordinated care of 4 hospitals, if we each are familiar and understand the reputations and quality of our providers, we can keep that work here in the North Country and float all 4 of the hospitals' boats higher. But we can do that together better than we can do it independent of each other. Timeline, right? As I spoke about earlier, we signed a letter of intent back in July. That's when we got together last. We've been working diligently on due diligence. Our boards approved the definitive agreement, the affiliation agreement, I should say, in the summer. We submitted our documents to the AG's office in August, and the AG's office and Cheryl Bust have been reviewing our documents. We have our public meetings now, and we hope to have an answer by the end of the year so we can have our first parent organization sometime in January. That's what we're hoping for. It's been about 2.5 years in the making. Our boards have all been extremely diligent in their work, studying other options, trying to figure out what is best for their communities, figuring out how we can make healthcare work better in the North Country. And we think through the affiliation agreement, the management services agreement, the bylaws changes, that we can do that. We were very confident that all 4 boards are on the same page and that the parent organization is really ready to take on this challenge. There will be an awful lot of work ahead. There will be a lot of folks questioning what we're doing. But I believe at the end of the day, it's going to be the best thing we can do for 4 hospitals in the North Country and all of the communities we serve and most importantly, the patients we serve. With that, I will turn it over to questions. What I will say before I answer any questions, yes, sir? This website has all of our documents available to you that are publicly available at this time. And we posted them publicly so we can be totally transparent with what we're doing. Yes, sir?
Chief Batchelder, Franconia, thanks. I do appreciate your enhanced communication and transparency. I think that's great. So I have two questions. One, you talk about assuming risk and having enough covered lives, or at least that's one aspect of it. So the first question is, what do you think is a viable number of covered lives to start to be able to assume risk? And are you close to that when you look at the total catchment of all 4 hospitals? So in other words, are you going to be able to take on some risk in a reasonable way?
I guess my first answer is to your question is we think we'll have about 50,000 population with the entire North Country. Depending upon which expert you talk to, they may say that's not enough to really cover risk. But what I'm going to say to you, 50,000 citizens to treat is a lot better to spread your risk than what we have here in Littleton at 9,000. So that's how I look at it.
And the second question is, I think it's great that you're talking about independence of the hospitals, but I guess there's a technical or regulatory issue. Does a critical access hospital, to maintain its critical access stature, need to have an independent board, or could there be one board that had multiple critical access hospitals?
We each need at this point in time to have our own board.
That's a requirement?
Yes,
to
sir.
be a critical access hospital?
Yes, sir. Believe me, we went down that road. Yes, sir.
Warren, I too, appreciate the transparency, and it seems all of this is a business that's a little bit foreign to me. That part of the important ingredient to make this thing work is that all 4 hospitals maintain their critical access designation. So, this new Country Healthcare Incorporated, how many employees are going to be employed by it?
Great question.
And how does creating a whole new level of very highly paid executives contribute to lowering healthcare costs?
First question, I'll answer it in 2 ways. We'll be about $250 million in net revenue, and there'll be about 1,500 employees. We believe through the parent organization, and we have 2 officers at the parent, that's all. That's what the manpower is at the parent. We will be able, 2, there won't be a whole slew of folks up there. We'll be able to help the hospitals reduce their cost by shared services, by synergies that we can work forward, by group purchasing. So all of the things that we can't do on our own, we believe we can drive costs out of the system that way.
Most of the cost savings that are recognized through mergers are the result of trimming out expenses. And by maintaining 4 completely independent hospitals and adding this new layer of administration, I know it sort of intellectually makes a little sense that you could, with brain power, lower the costs associated with it. But how many people, I understand how many people will be employed with the whole organization, but with this new corporation that's being formed, how many employees will be in that? Just 2?
From the onset, it's 2 people. It's a CEO and a president and CFO. We don't know where it'll evolve, but our goal is to try to keep resources, people at the hospital level. Deborah?
So are you saying that the parent organization is more likely to be the design in which you would find all these economies of scale and determine what would be the best fit for the 4-hospital affiliation and bring it to the individual boards of each hospital?
Yes and no, it'd be a little different than that, but the two individuals at the parent corporation, we see one of them as what I will call the planner. So planning the synergies, looking at what it's going to take to drive some costs out of the system, and the other one will be the implementer. We see a relationship, however, between the parent executives and the parent board, the hospital board, and the hospital presidents, and it's going to be a consensus building activity. So things aren't going to be pushed down to the local hospitals. It'll be a consensus building. How do we save money? Does this plan make sense? Does it work? Will it work? Should we pilot it? And we'll just take one opportunity down at a time. The other thing, back to your question, so as we think about what I do today, so I do strategic planning, I do everything for this institution to make sure they're successful, whether strategic planning and day-to-day operations. Our hospital presidents in this new role will be able to focus on day-to-day operations because a lot of that other work will be done by the system. So we'll have different people down here than we have today in a different capacity.
Well, I mean, I do appreciate, looking at new ways to structure this, but in a perfect world, is there an exit strategy that this doesn't work? I know.
Yes. After 3 years, at the 3-year anniversary date, any of the hospitals can get out. There's an exit clause built into the affiliation agreement, so they can get out if it's not working for them as an individual institution. Yes, ma'am.
The heliport at Weeks Hospital will not be utilized by the other 3 hospitals.
No, ma'am. The heliport at Weeks Hospital will only get used by Weeks Hospital. Every other hospital has their own heliport. Gary?
I saw one of your things up there was to achieve coordinated medical care. And it strikes me that I'm assuming that working together there may be efficiency. And also assuming that individual hospitals may employ certain specialists and all because they feel they have.
That's what they need, yep.
Now, is the result of this the possibility that if you need a certain specialty, that's in Lancaster or that's here, or on the contrary, would you have specialists, for example, that would tour? That is, they would be here Monday, they would be in Lancaster, and so that you might get greater efficiency in delivering the care.
I think it's all the above. I hate to say it that way, but it's a very good question. I think it's going to be, there may be, and just so you know, I can't sit here and tell you what's going to happen because obviously that's consensus building from the hospitals up to the system and coming up with these decisions. But as I think about it, we're going to probably have some centers of excellence, right, where you have to do a whole lot of volume to make sure you have really good quality and keep your costs down. We're probably going to have physicians that go on the road so we can get some of those services up into the North Country or down to Littleton that we don't have today so people don't have to drive as far. So it's going to be a combination of all the above based on cost efficiency, access, what's there now. So I think it's just a combination.
But specialists who are primarily serving
Littleton.
patients at one hospital,
Yeah.
maybe will be more likely to be serving
That is correct.
the entire population.
Or one or two of the other hospitals. It's really hard for a physician to go to, especially today. It's almost impossible for a physician to go to 4 different hospitals because quite frankly in the North Country we have 3 different information systems. That would drive them crazy. So part of our solution has got to be a new way of handling health information, right? Because we have different systems that don't talk to each other. That's a long-term plan. But short-term, we got to be cognizant about who's going where, how many different systems they need to learn, how we get the systems to talk to each other on a short-term basis. And long-term, quite frankly, we got to get everybody on the same platform. But, yes.
But the coordination without compromising the quality of health care could have significant cost savings.
Absolutely. And that's what we're looking at as well. Yes, sir.
And Warren, is there any thought being given in the thinking process, the population of the North Country today, tomorrow, next week?
50,000, 50,000, 50,000. Census seems to claim that really the North Country is going to stay flat for the next 10 years, and they have stayed flat. To answer your question, so that's another challenge, right? We don't have additional population coming in here to service all these hospitals, so we really do need to figure out how to work together. But we really, when we think about population growth, we don't see the census saying the population in the North Country is going to grow. In fact, the census population would indicate that the retirees in the area are going to grow, that women of childbearing ages are actually moving out of the area. So there's some other challenges that are going to approach us 10 years out. Any other questions? Yes, ma'am.
I certainly recognize the need to shave off costs to make healthcare more affordable, but in those conversations, I never hear about how those savings get passed on to the healthcare consumer. Right now, as a consumer in a high deductible plan, I have a very difficult time even finding out what the cost of a particular appointment or a lab test or a diagnostic is going to be. So is there any mechanism over time to figure out once you become more efficient, you negotiate contracts with your insurers that will pass those savings on to the consumer? And my second question was, you talked about how you lose business to the hospitals down south. People go to Dartmouth, people go to Boston, but right now it's impossible to find out the outcomes and how your outcomes compare to Boston's to a different hospital's outcomes. So as a consumer, it's very difficult. You can't find out what something costs, or it's hard to, and then you also can't find out, the success rate of your orthopedic surgery or whatever. So it's difficult to be informed.
So your first question, I think, was related to how do we make sure, as we drive our costs down in the North Country, that relates to lower premiums for health insurance?
Lower premiums, or if you're in a high deductible plan, what, not necessarily your premium, but what you pay a percent of that experience in the hospital. What does that savings ever get passed on?
It's a very interesting question, because at one point at Littleton, we had a 0% price increase. And when I talked to my friends at Littleton Coin Company, their insurance premiums went up 20% that year because of their experience. We don't have, the only thing we can control is our costs and our pricing. But we cannot control what the insurance companies does on the other side of the equation. And it frustrates me as much as it does you. With regard to your question about quality and cost at various hospitals, I can't speak for my peers because I don't know if they have that. If you go to our website, or if you ask our patient financial services department, we actually have an estimator where you can go on our website, put in the procedure you'd like, and we can estimate what your procedure will be. We also have a number of procedures that we bundle packaged, and you can get your pricing. With regard to quality scores are available by the federal government, and they're available on our website. And so we do make transparency, quality outcomes available to folks, as well as the federal government. If you would let us know how to get a hold of you, I can send you some websites to show you how to get onto quality scores.
Are those are quality and outcomes, not safety?
It's all the above. So they combine quality, safety, a lot of things that the federal government is asking us to measure. We have all that. And most hospitals for that matter, I think all hospitals in New Hampshire actually do that. They post it publicly.
Right, that's collected from CMS data?
Yes. Yes, sir.
Following up on her question, do you anticipate reducing prices over the next 3 years, but for the direct-to-consumer price for an offices, for an x-ray, or whatever?
If it was that easy for us to reduce prices and it would translate to your premiums to drop, I take to you yes, but it's not that easy. Because basically our insurance companies have a little formula, and it's very difficult to start dropping your prices, because as soon as you drop your prices, you're dropping, the insurance companies pay you less. So it's just a very complicated way to get there. It would be an ultimate goal of ours.
Do you anticipate raising your prices for individual procedures and office visits over the next 3 years?
We anticipate making sure we are market-based fees for our services. So we're in the market, whatever the market bears. We anticipate we have to cover the cost of our institutions. And our goal is certainly not to raise costs. So if we can take costs out and we can come into the communities in the North Country and say we don't need a price increase this year, that would be a dream.
You do not have any metric by which at the end of 3 years or even 1 year or 2 years, you would look at your prices then as compared to now and say, hey, this has been a success?
We have not gotten that far with our affiliation because we haven't been approved and we haven't been able to work with our boards and our parent organization. So we have not gotten to that point.
Will the pricing of office visits, x-rays, and other procedures be uniform among all 4 hospitals?
I don't know the answer to that, and I'm not sure I can do that yet. I just don't know legally I'm allowed to do that at this point.
I got a very different answer to that question last night.
Okay, I wasn't there. That's fair.
No,
Oh, please, if you were there.
I'm Bill Ardinger, I'm an attorney for the group. I was there last night. If your answer, Warren, was that you don't know about where prices will move because of the affiliation, that's the same answer that was intended to be given.
Well, as to the question that was posed last night about whether the pricing would be made uniform over all 4 hospitals, the answer essentially was yes, if the parent board decides that it wants to do that.
Okay then.
Is that fair, Bill?
I can agree to that.
That is the right.
That's fair. Again, I can't answer that until the parent board decides that's where we're going. I did.
Does the parent oversight the 2 executives? Do you have a strategy of what your first order of business will be, or is it too soon to ask that question?
We have a draft work plan that we want the parent board, once they're able to get together for the first time, to review and approve. But that draft work plan is a draft. It needs a lot more work in order for us to even present it to the boards. But we're not ready to start talking about what that is.
What will the access be to the parent company after the affiliation is
Access.
signed? In terms of knowing what the finalized work plan will be, say, for 3 years, 5-year strategy?
I think the access will really be more at each local hospitals as they have their community meetings and as they talk to their communities. Because really, again, this is about the community hospitals doing their jobs, not the parent organization. You know, in reality, we should be doing our jobs almost invisible of what, in the hospitals, that the community should be doing the work and doing the communication. Any other questions? Yes, sir.
Hi, I'm Patrick Miller. I'm on the Spear board.
Thank you for coming up.
Carpetbagger from Plymouth. So my question, you mentioned in the beginning, emergency department, diagnostic support services, and robust primary care
Yes.
were the core services. How does robust primary care happen, and what's the relationship with the new company in terms of what you deliver?
It happens a little bit differently in each of our communities.
Okay.
Here at Littleton, we have some employed primary care physicians that we employ, and we have a very good, close working relationship with our FQHC in town. So it's almost a 50-50 split of primary care practices. Upper Weeks Medical Center, they employ all of the primary care in that region, and they have them in rural health clinic status. I think he has 5 of those or 4 of those. In Berlin, it's the hospital in Berlin, ABH, I don't believe employs any primary care practices and relies totally on the FQHC in town for their primary care needs. And that is the same model that is up at ABH, so it's happening in every area. What I will tell you, though, is about 6 months ago now, time flies, might have been less, might have been more, 5 hospitals in the region and 3 FQHCs in the region applied for the AIM-ACO funding, which will bring us even closer together if we get approved for that. So we're really excited about that opportunity to work with the FQHCs and the hospitals in the North Country to try to improve care and really drive towards population health management and alternative payment mechanisms.
And that's where the risk might come from.
That is correct. So we're really excited about that. So if you think about what we're doing in the North Country, between the, what I'll call the structural changes that we can do with the parent organization and the procedural changes that we can hopefully do with the ACO, I think we can make some really good changes here in the North Country, drive our costs down, get quality improved, and be ready for population health management and alternative payment mechanisms, and survive in the future. Yes, sir.
Will there be one chief medical officer for the entire organization, or will there be 4 completely separate autonomous chief medical officers?
I can't predict your first question, because I don't know the answer to that. At this point in time, there's 3 chief medical officers, and we don't have one here at Littleton.
But is that then to say that if the parent board so decides, then there will be one chief medical officer?
I don't want to make hypotheticals, because I haven't had a chance to work with the parent board.
Will the parent board have the authority to make that determination?
The parent board, working with the hospital boards, can make that determination. That is correct. The one thing we have put on the table, and in a way we can engage our physician providers, is at the parent level, we will be developing a physician governance council made up of at least 2 members from each of the hospital's medical staffs, so we can start coordinating clinical care at the parent. But we haven't gone as far to talk about a chief medical officer.
Do you see a problem here in terms of losing flexibility in medical care among doctors? That is, for example, suppose you're going to a doctor here at Littleton Hospital. Suppose you were thoroughly displeased with the care here, and you decided instead that you would go to someone in Lancaster. Now, you might, as long as they are truly separate entities, you might be able to get completely different care. But if they're all, let me back up a step. Suppose you're dealing with a disease that is, for which there is not a standard of care, a very well-defined standard.
A best practice, okay.
It's a little bit unusual. You get very bad care in one place, you want to go to a different place and get, and hopefully get better care there. If there is one overarching medical officer or medical hierarchy with all 4 hospitals, will that prevent you, it seems to me that would prevent you from getting very different care somewhere else. Isn't that a concern?
I'm actually not sure I followed you, but if I followed you, let me see if I actually think that's how most big systems work today. I actually think if you were at Maine Health, for instance, and they have 14 hospitals or 10 hospitals within their system, there's going to be a little bit dispersion in care at each of the institutions. But what that chief medical officer is doing at the corporate headquarters is trying to standardize care, trying to implement best practices. So I'm not quite sure if I'm following.
That's exactly the problem
Well,
I'm getting at.
I actually think
standardization of care by one person. The way the care is standardized at one hospital may be different from the way it's standardized at another hospital.
But I don't think that has to be done by a chief medical officer. It could easily be done by a physician governance council, for instance, what we're proposing. Okay. Yes, sir.
What's the criteria that the AG's office uses to review this kind of agreement, or stated another way, I mean, what must you prove to them to get this approved? Is this like a financial review?
This is going to be easy for me. I'm going to pass the buck.
That's the best question, right?
I need to do that.
Well,
actually, our review is covered by the law. It's called RSA 7:19B. And what the
we all knew that.
Yeah, got it around the tip of my tongue. What the folks do is, whether it's this particular affiliation or Dartmouth-Hitchcock or someone else, everyone submits exactly the same type of information. It's governing documents. In this case, there's no change of control, but there would be a change of control document. The 2 things we really, really look at are, number 1, any restricted assets that you have. Now, as you've heard today, your restricted assets, in other words, someone gave money to Andrew Scoggin or someone gave money to Littleton, that remains with the individual hospital. That's not going anywhere. If there were any attempt to do that, that would have to go through the court process. That's not the case here. Number two, we look at the reserved rights. What does the parent get to do? What do the subsidiaries get to do? This is a little bit of an unusual affiliation. It's truly a North Country affiliation. As I said, it's a little unique, but it fits exactly what you need here in the North Country. We also review all the financials, including the Form 990, which is what 501c3s submit to the federal government in our office, and we look at the audits. We determine financial viability, a number of things that we look at. There does not have to be public meetings, but we encourage them, and certainly, as you know, there are 4 of them going on between last night and tonight. And then at the end of the process, we also talk with our antitrust attorney to see whether or not there are any antitrust issues here. Once everyone in our office says that the requirements of the law have been met, at that point, we sign off on the affiliation, and the affiliation goes forward. So that basically is what we do.
Thank you.
Sure.
Now I want to know how many people could recite that citation that we just got.
Our resident.
All right, our resident. Any other questions I can help you with tonight? Yes, sir.
In the course of negotiating all of this, have you been privy to the agreements that the other hospitals have signed with and
No.
You have not?
I have not been. We cannot share that kind of information, nor have we. Hey, Uma. How are you, sir? Any other questions? Yes.
I'll follow up on his question. Currently, you can't share that information before you can individuals. I think I saw in one of your previous slides that that's the intent if the parent is approved that that negotiation will be done at the parent level.
I think it's going to be dependent on a number of things. A, what we're allowed to do legally. B, what the individual insurance companies would like to do, because we can't dictate to them what they're going to do. And C, if there are insurance companies out there who want to enter into some kind of risk-bearing agreement with us, we will have to do it through the parent organization because it will have to include all 4 hospitals and it should be standardized at this point. But I don't know if all of our standard fee-for-service contracts will be negotiated that way or not. I can't answer that question today. That's it. Come on. There's a chance to pick on me. Oh, sorry. Mr. Starl jumped all over that one. So that's where we are today. We've done a lot of work. It's been 2.5 years probably in the making. We think we're in the red zone, if you will. What we put up here for you is if you have any comments, they certainly want to hear from you. And if you want to see our documents, they're available. And please take this information. If any of you had some follow-up questions and you did want to ask them, please track down Gail or Nancy and share them with you. Share your business card or your address with us so we can get you information. And I will certainly be happy to send you some websites. Please make sure I get your contact information. Please take some cookies to go. And I want to thank you very much for your time tonight. Not you, Dr. Green. Have a great night. Thank you.